Hello, everyone. Welcome to the third episode of our fracture conference. Today, we're going to talk about two topics, one fracture topic and one soft tissue topic. We're going to talk about a tibia fracture and a compartment syndrome that goes along with the tibia fracture. So we'll talk about the diagnosis of the tibia fracture, initial management, and then also the diagnosis of the compartment syndrome, the initial management of that, and ultimate definitive fixation of the tibia fracture. Really excited to have you here with us today. Please remember to follow us along on Twitter, RKH_MD. You'll see that down in the bottom left-hand portion of your screen. If you haven't done so already, please subscribe to our channel and like this video. If you have questions or comments, please leave them. We're excited and interested to hear your interaction with the cases. So let's get on with our case for today. Our patient's a 48-year-old female who was brought to the emergency department after being found down for undetermined amount of time. She was evaluated by the ED and trauma staff and was found to have a left tibia fracture. During her exam by the orthopedic surgery resident, she was found to have tense compartments and some mottling and bruising, some mottling and ecchymosis of her skin. I've placed a representative photo of what the patient's skin looked like on presentation. This is very certainly concerning clinical photo here. The patient's leg is very swollen, it's turning red, and there's severe ecchymosis throughout. If you look at the interlateral aspect of this patient's leg, you can see down in the darker area of ecchymosis that there may be even some early blister formation. So anytime you see a clinical picture that looks like this, we always want to be at least very suspicious of whether or not a compartment syndrome is forming or has formed. Here are the patient's tibia and fibula x-rays, and if you look at them, you can see there's a diaphyseal spiral tibia fracture that's associated with a fibula fracture. And if you look at the ankle, particularly the lateral view on the patient's ankle radiographs, you can see there's also an associated posterior malleolar fracture. This is actually a little bit bigger than most of the posterior malleolar fractures that we see in this injury pattern. So we also obtained a CT scan to more closely evaluate the fracture and the ankle itself. In particular, we want the CT to look at the ankle. But we can see here on the axial, sagittal, and coronal cuts this relatively non-displaced but still pretty large posterior malleolar fracture. Given the size of this particular injury, it's most likely that it came from the spiral down from the initial injury, but this is not exactly what you usually see. You usually see a completely non-displaced fracture when you are looking at these particular injury patterns. So let's talk a little bit about initial management of this particular patient. When you see this patient in the emergency department, as we discussed, you want to be very suspicious for at least evolving, if not already developed, compartment syndrome in this particular patient. Remember, in the initial presentation, I said the patient was found down. They were acutely intoxicated when they came into the emergency department. So there's not the clearest of pictures from the patient's standpoint in terms of them being able to give you a good story of what happened or how much pain they're experiencing. So from that standpoint, the patient history is a little bit difficult, but also gathering enough clinical information to decide whether or not you're concerned about compartment syndrome or if you're planning for a compartment release in this particular setting is very difficult. If the patient's altered, or in settings where you have very young children, or intubated patients, or delirious patients that can't provide a good clinical picture, you sometimes have to use other tools to help you decide. One of those tools that we have are compartment pressure monitoring. Now, I don't always advocate for compartment pressure monitoring. In a cooperative adult patient, you should never, in a cooperative adult patient, you should really never need to do compartment pressure monitoring. Either you're concerned enough about their physical exam that they have a compartment syndrome and you do a release, or you're not concerned and you continue to monitor the patient. Just as a review, what are some of our signs or symptoms of compartment syndrome? First and foremost, the patient has pain. I know that can be a little bit difficult because it's relatively rare to have a compartment syndrome not in the setting of something that's painful. So in this particular patient's incident, their tibia fracture is certainly very painful, and so you expect the patient to have pain. But you expect the patient's pain to be controllable with immobilization of the fracture and appropriate pain medication. If you treat the patient appropriately from that standpoint and they continue to have severe pain, and or they have pain when you examine them on a passive stretch of their compartments, then you really want to be concerned about the compartment syndrome. So pain out of proportion, pain with passive stretch, tight or swelling compartments with blister formation, those are all three really good telltale signs and can be early signs of compartment syndrome. When we get to some of the other symptoms that you read about in a textbook regarding compartment syndrome, things like paresthesias or colder extremity or pulselessness, then we've really probably gotten far into this development of the compartment syndrome, and we're starting to get to a place where we're worried about the limb becoming dysvascular. It's always important to be alert and concerned for compartment syndrome and to be aggressive if you're concerned that the patient might have a compartment syndrome. There certainly is nothing wrong with taking a patient for a 4-compartment fasciotomy and them not having a compartment syndrome. There's something very wrong with sitting on a compartment syndrome and let it develop and the blood supply to a leg be destroyed, and then you have a non-working leg that has the potential to become infected and could have even more devastating consequences from there. So it's always important when there's enough concern, either from physical exam or talking to the patient, inability to control their pain, to take them to the operating room. If you're looking for objective data to help you make a decision, and I can't stress enough that this is something that should help you make a decision, but really shouldn't be the most important decision maker when it comes to fasciotomies. Compartment pressure monitoring can be an adjunctive tool to help you understand what's going on under a patient's skin. So just as a reminder, all of the muscle groups are covered by this tight tissue called fascia. Fascia is a very unforgiving tissue, and so if there's any swelling within the compartment where that muscle is, then what will happen is eventually the swelling or the pressure will get so high that the diastolic blood pressure will be overridden, and there won't be a time for the leg to fill up with blood to allow for appropriate blood supply to the extremity. So again, we develop swelling either from muscle swelling or maybe from a hematoma or something that closes down the size of that compartment bound by a tight fascial covering, which decreases the pressure, and as the pressure overrides the diastolic blood pressure, then you don't have good flow of blood, and your extremity is not getting appropriately nourished with oxygen. This leads to muscle necrosis. It can lead to nerve death or nerve damage. Muscle necrosis can lead to severe infection. If the nerves aren't functioning, then you're going to have loss of motor and or sensory function in that extremity. And the results of missing a compartment syndrome can be very devastating for a patient. So it's very important that we be very vigilant and always thinking about compartment syndrome, and be incredibly aggressive when it comes to treating compartment syndrome. We have a device that's relatively simple. It's a pressure monitor hooked to a needle that's hooked to a syringe with saline in it. There are a variety of these. I'll show you a picture of what we use at our facility. It's a simple thing that allows you to measure the compartment pressures to help you with your diagnosis. So in our particular patient, the anterior, lateral, superficial, and deep posterior compartments were measured. Pressures measured were 46, 34, 54, and 30. 46, 34, 54, and 30. The patient's blood pressure when those measurements were taken was 141 over 82. And this is really important to help you decide if that compartment pressure is building to be overtaking the diastolic blood pressure. So if you're taking these compartment pressure readings prior to undergoing surgery, then utilizing the current blood pressure is okay. When you're measuring compartment pressures in the operative setting, you want to utilize the blood pressure that was taken before the patient started under anesthesia. That way you have an accurate diastolic blood pressure to compare to. So what do we define as a compartment syndrome? If your measured pressure is within 30 millimeters of mercury of the diastolic blood pressure, then you're concerned about a compartment syndrome. So in this particular patient, their diastolic blood pressure was 82. So the only pressure difference that's less than 30 would be that 54 measurement within the superficial posterior compartment. In the setting of a fracture, you want to measure your compartment pressures closer to the fracture site. This will give you the most accurate reading of your pressures in that compartment. What do you do with this sort of information? As I said, it's a bit of an adjunct to help you decide whether or not you want to intervene with compartment releases. In this particular patient, the clinical picture was concerning enough that when you add the picture or you add the information of even one compartment concerning, you want to go ahead and intervene and do 4 compartment fasciotomies to prevent muscle damage. So we have a patient that has a fractured tibia that has extension into the ankle joint and an impending or developing compartment syndrome. The other clinical piece with this patient, which I mentioned, is their acute intoxication. Certainly, you want to take them to the operating room to deal with the emergency, to deal with the developing compartment syndrome, to prevent loss of limb. But you may not be able, when you have a conversation with your anesthesia colleague, they may not want you to perform the definitive operation depending on how much time that might take. So you may have to consider staging something like this. In the setting of a tibia fracture with ankle joint involvement, then perhaps you would want to consider external fixator placement. This will allow you to continue to monitor the patient's skin after the fasciotomies before you are ready to do your definitive fracture surgery. So let's talk about our preoperative plan for this patient. In the first setting, given the concern for compartment syndrome, given the acute intoxication, we're going to plan for a trip to the operating room for emergency 4-compartment fasciotomy and external fixator placement. This will allow us to release the compartments, and stabilize the bone. I think the external fixator is a good option to allow us to examine the skin more frequently and to hold off until we know that the patient is ready for definitive fixation. It also gives time for the acute intoxication to wear off, so we know that it will be a safer trip to the operating room for definitive fixation of the fracture. So in the first setting, we take the patient. I choose to do 4-compartment fasciotomy through 2 incisions. I think that it is the more complete fasciotomy. It requires a little less dissection than a single incision fasciotomy. Sometimes when you're making just that lateral incision, it can be hard to dissect around and get to those posterior compartments. Puts the perineal nerve at a little bit more risk than the single compartment fasciotomy. For external fixator, a relatively simple construct: 2 pins above the fracture, 2 pins below the fracture, a pin in the calcaneus to span the ankle given the posterior malleolar fracture. This will allow us to hold the fracture and wait for the soft tissues to be amenable for definitive surgery. So here you can see some fluoro images. You can see our X-fix placement and the reduction of the tibia, as well as a good reduction of the ankle mortise, although that was not an issue. But we always want to make sure when we intervene that we don't make things worse than what they were before we started. In that initial setting, we just do the damage control procedures, fasciotomies, wound vac the fasciotomy wounds. There's certainly lots of ways that you can treat fasciotomy wounds. My preference is just simply to wound vac them the first time around and then come back in 48 hours to have a second look at the soft tissues and see the status of the muscle. So when you do 4-compartment fasciotomies through 2 incisions, you're going to make an incision on the medial aspect of the leg, just posterior to the tibia. This will allow you to release the superficial posterior compartment as well as the deep posterior compartment. You're going to just dissect the soleal bridge, I'll show a picture, off of the posterior tibia. That will allow you to completely decompress the posterior, both superficial and deep compartments. When you make that lateral incision, kind of in line with the fibula, you're going to dissect through your subcutaneous tissues until you find your fascia layers. There's sort of a little division between the anterior and lateral compartments. You can use that division to make your anterior fasciotomy superior or anterior to that division, and then your lateral fasciotomy posterior to that division. On that lateral side, you really just need to be careful for the superficial perineal nerve. It's really easy to identify and protect when you have a big incision. Some people might ask questions regarding doing bigger fasciotomy incisions versus smaller fasciotomies. In the acute setting, the bigger fasciotomy incisions are the preferred method. This allows for a complete release of all compartments. It prevents risk of not fully releasing one of the compartments. So this is the safest route to take. When you do your fasciotomies, you want to inspect the compartments. You want to take a look at the muscle and the health of the muscle. This will help you to get an idea of, 1, how bad the compartment syndrome was, but 2, to start planning ahead for how you're going to get those incisions closed at the end of the procedure. In really, really bad compartment syndromes, you can see the muscle really come out of the skin, and it can be a significant amount of time before you can get closure. Plus or minus, the patient sometimes requires skin grafts for complete closure. In this particular patient, after the fasciotomies, there was some swelling of the muscle, but overall the muscle was healthy. It was contractile when you touched the bovie to it, so it was alive, and it wasn't super swollen. So we got to this patient's compartment syndrome relatively early in its course, and we're able to prevent anything worse from happening. So after the initial procedure, we get the patient admitted back into the hospital. If we hadn't done a CT scan prior to the external fixator placement, then we'll get one after. In this particular setting, I'm not sure that getting one after really will help anything at all. This is a simple split of the posterior malleolus. So the first CT scan is sufficient to help us plan for our placement of screws to protect that posterior malleolus. 48 hours after the patient's first surgery, they had recovered from their acute intoxication. Their pain was significantly improved. We were able to monitor the soft tissues and the swelling had gone down significantly. So our plan for the patient's second operation, 48 hours after the first, is intermedullary fixation of the fracture with removal of their external fixator and IND of the fasciotomy wounds and potential closure. Let's talk a little bit about the posterior malleolar fracture. It's important that we address the posterior malleolar fracture before we begin our nailing procedure. We don't want to further displace or blow up the distal tibia with our reaming procedure or the placement of the rod. So we have to make sure that we get a good reduction of that piece, and also that we've placed our fixation, whatever we choose for that posterior malleolar fragment, in an appropriate location. So in my mind, there were two options for fixation of this posterior malleolar fracture. We could do a posterior approach and put a buttress plate on the posterior tibia. That would have required some screws in a position that I didn't really want to put them in. So instead, what we elected to do was to make sure we had a good reduction of our fracture and then place two cannulated screws that go from medial to lateral to capture our piece. Make sure we get them distal enough and keep them out of the way of the rod so that we can hold that posterior malleolar fracture in place. And you can see our fluoro images that show where we put those screws to hold that posterior malleolar piece. Once we're satisfied with the fixation of that fracture, then we can move on to the tibia. So let's talk a little bit about your options when it comes to intermedullary fixation of the tibia. First and foremost, you have really two approach options for the tibia. In this setting where there's a midshaft fracture, it really doesn't matter which approach you choose. I prefer the suprapatellar approach. I find it to be a much more friendly approach for getting a reduction of the tibia. It's a lot easier to do the procedure as a single surgeon, or if you're working maybe just with one other person. The suprapatellar approach is a lot simpler from the infrapatellar approach. So for suprapatellar, we're making an incision on top of the patella and then making another incision in the quadriceps tendon to get access to the knee joint, placing a protective sleeve posterior to the kneecap, behind the kneecap, and then doing our nailing procedure that way. In the infrapatellar procedure, you're going to make an incision just medial to the patellar tendon and then do a small medial arthrotomy to get access to the proximal tibia. Your starting point is the same no matter which approach you choose. So in the end, it really comes down to comfort with the procedure. I think at this point, the research has shown that there is no significant difference in terms of knee pain or complications when using one procedure over another. I certainly do think you need to be careful if you're going to choose the suprapatellar approach. You need to really pay attention to that protective sleeve and be certain that you have it in the knee joint at all times and that all of the work that you're doing is going through that protective sleeve. You shouldn't turn on reamers or any instruments until you know that you have them in the bone, and really be cautious the entire time of protecting that patella and the cartilage on the backside of the patella. So how do we do intermedullary fixation of a tibia? The first and most important thing that you need to do is create a starting point for your nail or your rod. That's done with a small wire. So we want to get a good starting point for our wire. We want the starting point to sit on the medial aspect of the lateral tibial spine. And I'll show a good picture of that. And then we want to sit just on the anterior shelf of the tibia. There's a little anterior bare space there that makes perfect entry point and stays away from the menisci and prevents any further problems. So I'll show pictures of what our preferred starting point is. You can see them on the screen. Again, in the diaphyseal fracture, the starting point is not as critical as if you're doing a proximal or distal fracture, especially the proximal fractures. The starting point is so important to make sure you don't have malalignment of your fracture. And we'll talk about one of those cases somewhere down the line and really dive into the starting point with the proximal tibia fracture and the importance of making sure that we get it right. At the end of the day, you want to see that your starting wire goes in the middle on both your AP and your lateral views. You want to be in the midline of the tibia. After we have an appropriate and perfect starting point, then we can use a drill to open our canal and start our reaming procedure. So we use a beta tip wire, which allows us to pass the reamers over. The wire is also sort of an important portion of this procedure. It's good to put a little bend in the distal aspect of the wire. You don't want to go too big, but you want something that allows you to drive that wire through the metaphyseal bone in the distal aspect of the tibia to make sure that you have that rod ending in a perfect point. Once we're sure that we have the reaming rod in a good position, so we want to reduce the fracture on the AP and lateral planes, pass the rod down, and get that wire in the center of the talus. So we don't want to be in the center of the tibia itself, we want to be in the center of the ankle joint. So what we're concerned about is the alignment of the leg. So making sure that you're in the center of the talus or in the center of the ankle joint is going to get you good alignment. That's your AP. And then when you look at your lateral view, you want to be in the middle from the A to P dimension. You want to be in the center of the tibia. This will allow us to ensure appropriate alignment of the tibia and prevent any misalignment in varus or valgus as we pass our rod. So we have our wire in a good location. We've made sure that our fracture is reduced. Always remember, you cannot count on reaming or placement of your rod to reduce your fracture. You want to have a reduced fracture and then start your reaming process. So we have an in-cutting reamer that's 8.5 millimeters in diameter. That allows us to make sure we have a good path created. And then we start reaming up. I like to start at 8.5 millimeters and ream in 1 millimeter increments until we're getting to a place where there is bone contact with the reamer, and you can hear that as you're listening to the reamer go down. We call that chatter. So as we start to get chatter, then we start to work our way up by 0.5 millimeter increments until we're satisfied with our reaming. I like to ream 1 millimeter greater than my planned implant size. So as I'm reaming, if I start to get chatter at 10 and I think that we're going to have that a 10 millimeter nail is going to be good, then we'll ream up 10 millimeters, 10.5 millimeters, and 11 millimeters. And after we ream 11 millimeters, we'll put the rod in. Some people like to go 1.5 millimeters over their implant size. There really is no difference what you choose. So after we've reamed up, we have a reduced fracture, we can place our rod. So we've measured the length required, and we'll place the rod over top of the reaming rod down into the tibia. will confirm reduction of our fracture. So you can see our fluoroscopy images, and we see that we have a good reduction of our fracture in the AP and lateral plane. We can also see that we have a good overall alignment of our tibia. We haven't malreduced the leg in a varus or valgus position. After you have your rod in place, you have to secure it into the bone. The fracture pattern to me really dictates the number of screws that are required in the nail. Sometimes I'll place 2 up top and 2 below. Usually it's depending on where the fracture is. So higher fractures get more screws up top than below. Lower fractures get more screws below than higher fractures. If I'm getting into what I consider to be more of an extreme nailing, where we're really getting a fracture fragment that's going to be close to where the distal or proximal screws are, then I'll put more screws and put screws in more planes. In terms of our screw placement for this particular procedure, we place 2 screws distally and 1 screw proximally. That should provide plenty of sufficient fixation for this particular fracture pattern. You can see the screws going from medial to lateral. There are also opportunities to do off-axis screws, both proximally and distally. And if we're getting really close to the fracture, if the nail or the screws are really close to the fracture fragment, then I'll use those off-axis screws to provide more rotational stability of the fracture. We were able to close the patient's fasciotomy wounds secondarily without any problems. They looked really good. From a weight-bearing standpoint, my plan with this particular patient is to protect the weight-bearing a little bit longer than I normally would. I think that posterior malleolar piece is significantly larger than what we see most often in this fracture pattern, and I want to give that intra-articular fracture a time to heal. So we'll keep this patient non-weight bearing for 6 to 8 weeks, depending on what we see with healing, to allow that posterior malleolar piece plenty of time to appropriately heal. Here we see our first set of follow-up radiographs for this particular patient. We saw them 1 month out from their injury. You can see we have a fracture in good alignment. The ankle mortise is in good alignment. And we have healing fasciotomy wounds and patients doing well. So we're going to hold off for another 4 weeks of non-weight bearing. And we'll bring a follow-up back after we have a fully healed fracture and show everyone what the final result here is. But so far, the patient's doing very well and progressing nicely with healing of their fracture. So this is our case example of a tibia fracture in a patient that has an impending compartment syndrome. I hope that you enjoyed the case. Again, remember, if you have questions or comments, please leave them below. We'd love to hear from you, and we'd love to hear your thoughts on this particular case. For our journal club articles, I'm going to post a couple articles below about suprapatellar nailing and outcomes comparing suprapatellar nailing and infrapatellar nailing. In the trauma world, there's certainly a lot of strong opinions one way or the other, and I think that both do a good job of achieving the goals of getting a reduced fracture that is stable. Certainly there are much stronger indications for the suprapatellar nail, and we'll find some cases along the way of the more proximal fractures and talk a lot about why suprapatellar nailing may be a much better choice for those more proximal fractures. In terms of our poll questions for this week, I have 5 questions for everyone. The first question is probably relatively obvious, but I want to see what percentage of people are doing supra versus infrapatellar nailing, those of you who are fixing tibia fractures. I want to talk a little bit about what your preferred screw configuration is. So I'll ask about number of screws up top versus down below, as well as medial lateral versus the more off-axis screw placement choices. I want to hear from all of you what you prefer for weight-bearing status after a tibia fracture like this. Are you more of a weight bearing as tolerated? Do you protect weight bearing for a short period of time? Last question, also including the ankle fractures, to see how that changes opinions in terms of weight bearing. And I'm also curious to hear how you protect your fasciotomy wounds after closure. Do you use a splint? Do you just use soft dressing, which is everyone's dressing of choice? And then I think I'll include one more question, excluding the fasciotomy closure, what people use after this procedure in terms of, do you put a patient in a boot or a splint or nothing at all? Thanks for listening today, everyone. Again, please subscribe, like this video if you liked it, leave comments or suggestions below. Follow me on Twitter, RKH_MD. That's where the poll questions will be. I look forward to hearing from you all, and we'll see you all next week for our next fracture conference.